Hello and welcome to another edition of Health in the Heartland, a program dedicated to the health issues that affect you. I'm Karen Blaiklock, and joining me in this episode are guests Dr. Cundiff and Dr. Kaini, physicians who specialize in pulmonary and critical care with Heart and Memorial Health. Welcome and thank you for joining us.
Thank you for having us.
We're going to start talking, and I guess our topic this episode actually is lung disorders. And according to the American Lung Association, about 35 million Americans have chronic lung disease. Dr. Cundiff, actually, what defines chronic lung disease?
Any kind of disease of the lung, such as COPD, asthma. There's several types of pneumonias that are chronic in nature, interstitial pneumonias. Pulmonary hypertension, which is high blood pressure that affects only the lungs. These are all just examples of chronic lung disease that we see in our clinic.
So it sounds pretty much like diseases that affect our respiratory system.
Correct.
So that would be anything with our lungs and our breathing, which is essential to living, really. Yes. So with that many Americans actually having those types of disease processes, I heard you mention COPD. Dr. Kaini, what is COPD?
COPD, according to Gold Initiative for Chronic Lung Disease, COPD is defined as any chronic disorder of lung which causes obstruction to airflow, and it's not fully reversible. It is very life-threatening condition which is chronic and progressive but underdiagnosed in community like ours.
So generally, is that an age population of younger individuals or older individuals? And when we say chronic, that's usually something that's gone on for a period of time, correct?
Yes, it is chronic progressive, and because most of the times it is associated with smoking for a long period of time. It is usually affecting mostly people over 45 years and above. There are times when there are younger people who are affected if they are chronic heavy smokers or problems with other genetic issues or environmental issues.
So I heard you mention smoking. So that people that have chronic obstructive pulmonary disease, which is the COPD, what type of person is at risk for that? Somebody who does smoke, and anything else?
The most significant risk factor for COPD is smoking, and it is proportional to the diagnosis of COPD, and the severity of the disease is proportional to the amount of smoking you do over the years, the numbers of cigarettes you smoke per day, and the number of years you smoke over your lifespan. And that is critical in terms of diagnosis of COPD and how severe the disease is.
Now, we've talked about what person might be at risk for COPD. What type of symptoms does an individual come to the office exhibiting with COPD?
Chronic cough, shortness of breath, worse with exertion, cough with sputum production, wheezing, and again, most of these symptoms are worse when the patient is doing some sort of activity, because it usually is a problem with getting air out of the lung. So they need a little bit more rest and time to recuperate when they do activity. So oftentimes people will notice, they have trouble walking up the stairs, or they have trouble carrying their laundry basket to their bedroom.
And those sound like things that are activities of daily living. I mean, things that we take for granted. So when it starts to impede upon such things as getting up from a chair and walking across the room, like you said, taking the laundry basket, that's when they really need to talk to their physician and definitely seek some assistance, correct?
Correct.
How do you diagnose those types of diseases such as COPD?
Well, the way to diagnose COPD is through a test called a pulmonary function study. And it takes about 30 minutes to complete the test. And it is a series of tests where we measure how much air the patient can get out over certain time spans. And we look at the ratio of how much air they can get out in 1 second compared to how much air they can get out of their lungs totally. And if it falls below a certain category, then they fit the diagnosis of COPD. And then based on a particular number of how much air you can get out over 1 second, that grades the severity of the illness.
So what type of treatment, Dr. Kaini, would an individual that has COPD have?
The only proven treatments for COPD, there are I'd say 3 proven treatments so far. One is smoking cessation, that's the #1 priority. Then oxygen therapy, providing oxygen over certain hours per day, every day, for those patients who have lower oxygen level. And then there are certain surgeries like lung volume reduction surgeries that help in these people. But there are other treatments, pharmacological and non-pharmacological treatments, which we could provide to the patients to alleviate the symptoms and to get a better quality of life for the patients.
So really, to stop smoking, then to look at the oxygen therapy that might help them breathe obviously better and be able to do those activities that we had talked about.
Yeah.
I would assume maybe even the sleeping and those types of things too, but you said more on exertion, I think.
Yeah.
Is that correct? And then the drug pharmacological treatments that might open their airways to help them breathe better?
Better, yes.
Wow. Okay, now we've talked about COPD. What about the individuals that have asthma, Dr. Cundiff?
Well, asthma is a obstructive lung disease that is reversible by definition. So these patients oftentimes have the disease since childhood. And by reversibility, we mean that with treatment with a particular inhaler, their lung disease, their symptoms are much better. And oftentimes they can be fully reversed with appropriate treatment. So these patients, unlike COPD, that their disease is fixed and from damage by cigarette smoking, asthma is usually a allergic reaction to some sort of antigen in the air causing acute airway obstruction.
So those individuals, it sounds like our age span might be a little bit different. They could affect children and then also adults, is that correct?
Correct.
And then with asthma also might be managed a little bit more based upon what the triggers might be?
Correct. I mean, the recommendations are to you identify the triggers that the patient may have. If the patient gets symptomatic when they're around somebody that wears strong cologne, then they try to avoid the cologne. They try to avoid smoke because lots of patients can be made symptomatic by being around smoke. Different sorts of dust, environmental triggers such as certain chemical smells, all these things can trigger the asthma, and that's the recommended first approach, is to avoid all triggers.
Can you actually outgrow asthma?
Some patients' symptoms get better with age. Usually when they outgrow the asthma, they've been treated appropriately with inhalers, or they've did a good job of avoiding their triggers, changing jobs, for instance, or changing a house, changing where you live if you're around lots of dust or mold.
So for asthma, we actually mentioned that they need to identify the triggers, and there might be some medications that might assist, and then usually the inhalers to help them open up their airways and breathe a little bit better too. What are signs and symptoms of asthma, Dr. Kaini?
The most common signs and symptoms for asthma is shortness of breath, chest tightness, wheezing, and when they are having exacerbations, usually it's wheezing and chest tightness that people come in with. They also could have cough, sometimes sputum production, because most of the asthma are exacerbated by either allergic symptoms or by any environment pollution or even infection at the time.
We talked about, and I had asked the question about outgrowing asthma, but actually you don't have to have childhood asthma to have asthma as an adult. Could it happen at any time?
Yes. I mean, oftentimes a patient comes in their 40s, 50s, 60s, or even later with new onset asthma. They could have been exposed to a particular substance, chemicals at their job or whatever that could actually trigger and cause induction of their asthma. So it doesn't have to be at any particular age.
Okay. Now we've talked about COPD, we've talked about asthma. What about chronic bronchitis? Do you see individuals in your office that might have chronic bronchitis, Dr. Cundiff?
Yes, chronic bronchitis actually fits into the one of the subdivisions of COPD, and those patients typically have chronic inflammation of the airway causing sputum production and inflammation of the airway. They behave very similar to patients with COPD because they actually fall into that category. They have a chronic obstructive lung disease.
So then they're treated similarly and hopefully can manage that so that they can have the quality of life too.
Correct.
Okay, we've talked about, again, COPD, asthma, bronchitis. Do you see individuals in the office possibly that might have cystic fibrosis?
We've seen few patients with cystic fibrosis so far, and cystic fibrosis is a genetic disorder with problem manifesting as pulmonary problems as well as other systemic diseases like pancreas, liver, GI tract. It usually presents, the patients are usually young, in 20s to 30s most of the times. Now, with improved therapy, the lifespan of cystic fibrosis patients have gone up, but still, and we have started seeing the cystic fibrosis patients in our clinic right now. And most of the times they're present with chronic cough and lots of problems with airway clearance and colonization with multi-drug resistant organisms. And they have to be managed very closely with pulmonary follow-up multiple times a year and very close watching.
So it sounds like when you said genetic, you're actually born with cystic fibrosis.
Yes.
And then that patient, not only it affects their lungs, but they have multi-systems that they need to maybe see other specialists in that area too. But one of the areas that they would come is definitely to the pulmonologist.
Yes.
Yes.
Yeah.
So I think as we talk about the types of patients that you see in the office, I think one of the tips then for general population would be, I heard, not smoking. So tell us a little bit about how an individual could go about stop smoking so that they might be able to breathe a little bit better, Dr. Cundiff.
Correct. This is one of the most addicting substances on the face of the earth, so it's a very hard habit to stop. Some of the effective treatments we have are nicotine replacement therapy, and the most proven therapy to facilitate smoking cessation is dual nicotine replacement therapy. So the application of a patch as well as use of a lozenge or chewing gum when you get extra cravings. There's also several other medications that we can use. One of the medications is called Chantix. There's another medicine called Wellbutrin. But the single most important thing that impacts smoking cessation is the patient's willingness to quit smoking.
And we must mention, because it is very tough to stop smoking because it has become so addictive and that habit is there. And the body actually then craves that nicotine, but actually working with those different types of therapy support groups, it can be overcome and is something that can definitely change your life.
Correct. I mean, smoking causes accelerated loss of lung function. So with any diseases that we mentioned, it can compound and actually cause accelerated deterioration and actually development of other diseases, such as lung cancer.
Now we're talking about smoking and we've mentioned asthma. We haven't really talked about pulmonary emphysema, and I want to get into that in just a minute too, but not only the patients that you see, but if they are around smoke, so that secondhand smoke can definitely affect their breathing, and most of the patients that you're seeing in the office too, not only if they smoke, but if they're around the secondhand smoke.
Correct. Secondhand smoking does facilitate loss of lung function, and actually not just the breathing the smoke from secondhand smoke, it's actually being around things that are saturated with the smoke, such as furniture or clothing, can actually trigger other people's symptoms. Or, for instance, somebody who has asthma, if they're around somebody who smokes, or they go to somebody who smokes house and they're around the furniture that is saturated with the cigarette smoking, this can actually trigger their symptoms and make their symptoms worse.
Make it very difficult. Now, I had mentioned pulmonary emphysema. Dr. Kaini, what's the definition really of pulmonary emphysema? We hear that term too.
So pulmonary emphysema is part of chronic obstructive lung disease itself, and it is defined pathologically with destruction of the bronchial tubes below the terminal bronchioles with permanent dilatation and destruction of the alveolar sacs, the sacs where the oxygen gets transported to the blood and carbon dioxide comes out. And that's why we see the problem with low oxygen level and problem with hypoxia and shortness of breath with exertion.
So I think if I'm getting the picture, so we can maybe give that to our audience here, we have chronic obstructive pulmonary disease kind of as the umbrella, is that correct? And then
Yes.
we have pulmonary emphysema, we have the chronic bronchitis, and other things that actually make up the chronic obstructive pulmonary disease. Is that correct?
Yes.
Are there any others that we need to mention that might fall underneath that umbrella, Dr. Cundiff?
Untreated asthma can lead to chronic obstructive lung disease and give you a picture much like COPD. When asthma is untreated or you're around triggers of the asthma consistently, the airways can actually remodel and resemble that of someone who has a COPD.
Okay. Do we have any healthy tips, I guess, to give as far as what we can do to keep our lungs healthy? I know we've mentioned stop smoking. Are there any other things that we might need to take into consideration?
Exercise. Exercising, and even in these patients that we mentioned with COPD and asthma, exercise has been shown to improve the quality of their life and to actually help prevent or delay loss in lung function. Appropriate vaccinations, such as the flu shot, the pneumonia shots. There's now 2 pneumonia shots that the Centers for Disease Control are recommending. One is called the pneumonia vaccine, Pneumovax. The other is called Prevnar. Both of them protect against different bacterias. And if you meet the criteria based on age and certain disease states, then appropriate vaccinations are very important.
So definitely they need to talk to their primary care physician about the vaccination for flu and then also for pneumonia, as you had mentioned. Stop smoking. We know we all need to exercise. It's good for us generally for our health too. When we talk about pulmonary disease, we've talked a little bit about treatment, a little bit about diagnosing. What other types of diagnosis or procedures do you actually perform?
We perform a procedure called bronchoscopy, and that's the insertion of a camera through the mouth and into the lungs. By doing that, we can sample people who may have tumors. We can sample any fluid in the lung that could be infectious. We also do a procedure called thoracentesis, where we place catheters through the ribs into the chest to actually drain fluid out from around the lung. Those are the big procedures that we do.
So we've talked about treating people that have pulmonary disease, but also with the critical care component, we know breathing is essential to life, so you are also involved in a lot of other cases in assisting maybe individuals that might have had other things happen where they need to be able to breathe and their lungs might be involved during those episodes too, correct?
Correct. Critical care is an all-encompassing specialty, and usually it can involve any sort of organ system that is failing. For instance, patients may have kidney failure or heart failure, causing them to not be able to handle fluid appropriately, making them have difficulties breathing. Oftentimes we're involved in those cases. These patients are oftentimes in the hospital. People who have significant bleeding or infections can have disease states that make it hard for them to breathe and typically find themselves with the need for a critical care doctor to care for them in the hospital.
Right. So you're really working, not only seeing patients, but also then working with the team of specialists with the critical care
Yes.
in the inpatient and outpatient situation. And we're lucky to have you here in our community to be able to care for those types of patients that we have. Anything else we need to discuss today with lung disease and lung disorder to share with our audience?
The big thing I would stress is the importance of smoking cessation. And you know, Kentucky is the state with the highest percentage of smokers adjusted for the population. About 1 in 4 people in Kentucky smoke. And smoking is the single biggest risk factor for all these lung diseases. And just, you know, stressing the importance, and even if you fail a couple times, you know, always get back up and try again, because it's never too late to quit, and stopping can actually prevent people from getting much sicker.
Yeah.
Excellent preventative message.
And it takes at least 5 to 6 times for a chronic smoker to quit smoking overall, at least. And there are many cases where it takes up to 10 times. So every time when they go to doctor, talk to the doctor about what they can do for a smoking cessation, and doctors working with the patient, providing supportive care as well as pharmacotherapy to help stop smoking would be great.
Excellent supportive message. Well, we appreciate you being here with us during this episode. And for more information regarding lung disorders and lung disease and even smoking cessation, we invite you to go to our website at www.hmh.net. Another resource for you might be the American Lung Association at www.lung.org. Thank you again for joining us this episode, and we hope you tune in next month for another important edition of Health in the Heartland.